85% of patients with refractory angina, severe chest pain that fails to respond to aggressive medication or bypass surgery, experience a profound reduction in symptoms after undergoing Enhanced External Counterpulsation, or EECP. The physical mechanics of EECP are straightforward. It utilizes ECG-gated, sequential pneumatic compression of the lower extremities. ECG-gated means the compression is precisely timed by a computer to match the electrical rhythm of the patient's individual cardiac cycle. This split-screen diagram highlights a glaring discrepancy in the clinical data. While patients report massive symptom relief, objective SPEC imaging, which maps blood flow through the heart, shows a flatline graph. There is zero measurable change in blood flow to the ischemic regions of the myocardium. This lack of perfusion contradicts the primary medical assumption of cardiovascular therapy. Standard practice dictates that to resolve angina, a treatment must deliver more oxygenated blood to the starving heart tissue. If blood flow to the ischemic heart tissue is not increasing, the established clinical model for understanding how this therapy functions is incorrect. These two vector diagrams compare the standard assumption, the central hypothesis, against the therapy's actual mechanics. The medical community assumed EECP acted simply as a non-invasive intra-aortic balloon pump, or IABP. An IABP is an invasive catheter device that inflates inside the aorta to help the heart push blood. The theoretical goal of this central hypothesis is mechanical. By pushing blood backward toward the heart during diastole, the pressure was supposed to drive coronary angiogenesis, the physiological process where new collateral blood vessels form from pre-existing ones, thereby increasing direct oxygen supply. Comprehensive radionuclide studies have dismantled this theory. Across multiple multi-center trials, scans definitively show no new collateral vessels and no increase in oxygen supply to the heart post-treatment. EECP does not resolve angina by increasing oxygen supply. It resolves angina by drastically reducing myocardial oxygen demand. The data supports an entirely different mechanism of action, known as the peripheral hypothesis. The true target of the peripheral hypothesis is systemic endothelial dysfunction. The endothelium is the thin, single-cell membrane that lines the entire interior of the vascular system, actively controlling blood vessel relaxation and contraction. EECP is a systemic vascular intervention. It resolves localized cardiac pain by altering the patient's entire circulatory environment. The physical process begins when pneumatic cuffs inflate to 300 millimeters of mercury. They fire sequentially from the calves to the lower thighs to the buttocks during early diastole, the resting phase of the heartbeat. At the precise microsecond that early systole begins, when the heart contracts to pump, all the cuffs deflate simultaneously, instantly removing the external resistance. This rapid squeezing and releasing generates extreme endothelial shear stress, or ESS. ESS is the physiological friction created by blood dragging against the inner vessel walls. Looking at this vector diagram of human blood flow, we see the immediate physical response. In the upper body, forward-moving flow spikes. Shear stress in the arm's brachial artery increases by 75%. At the same time, compression forces a massive wave of backward flow down the legs. Shear stress in the proximal femoral artery explodes by 402%. Applying these episodic extreme waves of friction directly to the muscular conduit arteries acts as a physical dose of vascular medicine. The mechanical compression creates a highly therapeutic level of friction against the endothelium across the entire vascular tree, setting the stage for deep cellular changes. The physical friction of this shear stress triggers mechanotransduction, the process where cells convert physical mechanical stimuli into chemical activity. As the cell wall bends under the intense fluid pressure, it initiates a biochemical cascade within the blood vessels. The immediate cellular response is the upregulation of endothelial nitric oxide synthase, or eNOS. This is the specific enzyme responsible for producing nitric oxide, the critical molecule that commands blood vessels to dilate. This chart plots the chronic biochemical outcomes of a standard 35-hour treatment regimen. Patients display a sustained 36% increase in plasma NOx, a reliable measurement of total nitric oxide production. Simultaneously, levels of Endothelin-1, a potent peptide that causes blood vessels to constrict, drops by 25%. Levels of ADMA, which inhibits nitric oxide, also fall by 28%. With ADMA suppressed and eNOS upregulated, the newly available nitric oxide drives a systemic anti-inflammatory cascade. This cascade chart tracks the measured drops in specific pro-inflammatory cytokines. Tumor necrosis factor alpha falls by 16%, and high-sensitivity C-reactive protein drops by 32%. The increased nitric oxide directly inhibits the expression of MCP1 and VCAM1, molecules that normally recruit white blood cells to stick to the vessel walls. This active suppression halts atherogenic endothelial activation. 35 hours of mechanical compression rewires the patient's baseline vascular biochemistry, shifting it from inflamed and constricted to dilated and protected. This peripheral biochemical shift connects directly back to the physical workload of the left ventricle. The increased systemic nitric oxide improves flow-mediated dilation, or FMD. FMD is the ability of a blood vessel to widen in response to increases in blood flow, serving as a primary indicator of arterial health in the peripheral muscular conduit arteries. As widespread peripheral dilation takes effect, overall systemic arterial stiffness passively drops. This graph plots an aortic pressure waveform. When the left ventricle pumps, it pushes a forward-traveling wave of blood. When that wave hits peripheral arteries, a reflected pressure wave bounces back. In stiff arteries, it returns quickly, crashing into the aorta during ejection. This extra energy the heart expends is wasted left ventricular pressure energy, or LVEW. But as arterial stiffness reduces, the reflective wave's return is delayed. The wave arrives later in the cardiac cycle, safely entering the aorta during diastole while the heart rests. The left ventricle no longer has to fight against its own augmented pressure. This shift results in a drastic reduction in LVEW after 35 sessions of EECP. This massive reduction in myocardial oxygen demand, not an increase in oxygen supply, is the true reason refractory angina vanishes. Accepting the peripheral hypothesis expands the clinical implications of this therapy far beyond cardiology. Because the treatment rehabilitates the entire peripheral vascular tree, its benefits cannot logically be confined to the heart. Improving systemic endothelial function naturally targets diseases characterized by microvascular ischemia, the restriction of blood supply in the smallest blood vessels, regardless of location. A 2019 geriatric consensus outlined data demonstrating the therapy's efficacy in treating diabetic microvascular complications. Specific non-cardiac ischemic conditions, including diabetic retinopathy, sudden hearing loss, and erectile dysfunction, objectively improved following treatment. The endothelium is the common denominator. Treating it systemically treats the downstream organ failures simultaneously. The ultimate test of systemic vascular rehabilitation is the brain. The shear stress generated by the treatment modulates cerebral autoregulation and increases flow velocity through the middle cerebral artery. This increased cerebral perfusion drives objective improvements in post-acute ischemic stroke rehabilitation. In August 2024, clinical data linked this enhanced perfusion to the treatment of long COVID. Long COVID patients suffering from objective cognitive impairment saw significant improvements in their composite cognitive scores post-EECP. This cognitive reversal connects back to the core mechanism, clearing systemic inflammation and reducing endothelial stiffness to restore capillary flow in the brain. The data requires a complete recontextualization of the therapy by the medical and research community. EECP is not a localized mechanical cardiac assist device. It is a high-dose, non-pharmacological mechanotransduction therapy that heals the entire human endothelium.